penceramah kita, Dr. Hafizuddin bin Muhammad Fauzi, panelis dan juga peserta. So saya nampak sehingga sekarang sudah ada 28 peserta. Okey, so sebelum kita mulakan sesi perkongsian ilmu kita pada petang ini, so saya perkenalkan dululah kita punya penceramah. Okey, Dr. Hafizuddin bin Muhammad Fauzi adalah pakar perubatan lah di Pusat Perubatan USM Bertam. Beliau bertugas sebagai pakar hematopatologi di lab clinical diagnostic lab di PPUSM Bertam. Okey, so baik, diharapkan dengan perkongsian ilmu pada kali ini, para peserta dapatlah mengetahui dengan lebih jelas apakah itu coagulation screening test, apakah tujuan coagulation screening test dan agak-agaknya bila yang kita perlu untuk menghantar coagulation screening test ni ya. So Dr. Hafiz akan memberi penjelasan dengan lebih lanjut sama ada ia adalah rutin test ataupun tidak. Okey, sekiranya para peserta ada soalan yang ingin ditanya kepada penceramah, bolehlah menaip dia dalam chat box. Okey, saya akan bacakan semua soalan dia pada akhir sesi perkongsian ilmu kali ini ya. Okey, untuk tidak melengahkan masa lagi, saya silakan saya jemput Dr. Hafizuddin untuk memulakan ceramah ataupun perkongsian ilmu beliau. Silakan Dr. Hafiz.
Okay, terima kasih Dr. Sharifah atas perkenalan tersebut. Okey, Assalamualaikum semua. Terima kasih saya ucapkan kepada semua para pendengar yang sudi hadir pada petang ini untuk kita berkongsi ilmu majlis ilmu pada petang ini yang bertajuk Coagulation Screening Test. Is it a routine practice? Jadi target partisipan saya pada petang ini adalah mainly internal sajalah, melibatkan doktor dan nurses dan juga maybe ada orang awam maybe mungkin kepada kalian jika ada share dengan kawan-kawan Jadi okay, sekejap. Okay. This is my outline of presentation. We will talk about coagulation and hemostasis process. What are the coagulation screening tests and its limitation? Part of pre-analytical issues, untuk mendapatkan result yang bagus, kita kena tengok apa isu-isu dalam pre-analytical yang kita kena tahu. Overview of purpose of hemostasis testing. Kenapa kita hantar test ni untuk apa? Dan akhir sekali conclusion. Okey, part pertama ialah berkenaan coagulation hemostasis process. Ia adalah a combination of a number of events that occurs in a sequence following the breach of vascular integrity, and the main aim is to arrest the bleeding. Okay, and it is an orderly process which is started with initiation, termination, and also removal of the end product. Excessive, we don't want excessive end product. So apa yang nak dikatakan sini, kita cakap bahasa Inggeris Melayu sikit, layman sikit. Jadi apa yang nak dikatakan ini, bila kita ada vascular breach of vascular integrity, maksudnya jika contohnya ada luka, jadi aim hemostasis process ni adalah untuk stop luka tersebut. Alright? Jadi ada beberapa proses yang berlaku secara turutan di mana kita start dengan primary hemostatic plaque, lepas tu kita akan stablekan plaque tersebut dan kemudian removal of excessive plaque supaya kita tak ada thrombosis yang block salur darah. Okey, terdapat 5 important components dalam coagulation process which involve blood vessels, platelet, coagulation factors inside our blood, coagulation inhibitors inside our blood too, and lastly fibrinolysis. Ini refer kepada proses removal just now. Jadi kalau kita tengok gambar rajah di sini, ini umpama blood vessel, terdapat luka, injury or damage the blood vessel, right? So the first perkara yang akan berlaku ialah vessel constriction. Nampak tak gambar ni dia lebih constrict. Untuk kita tujuan dia constrict ni adalah untuk mengelakkan blood daripada terus keluar. Kemudian platelet dalam darah kita akan berkumpul bersama sendiri membentuk platelet plaque. Dan akhir sekali coagulation factor iaitu secondary hemostasis akan play a role where fibrin clot will be formed. Fibrin clot will be formed at the site of the injury to stop the blood from coming out. Okay. Okay, this is another diagrammatic view what I have talked about. First is vasoconstriction, where the site of injury, the blood vessel will constrict. And then primary hemostasis will occur, the next stage, which the aim is to gather all the platelet to form primary plaque at the injury site. And then secondary hemostasis, all the coagulation factor will play a role forming fibrin. Fibrin at the site of injury. And lastly, there will be thrombus and antithrombotic event, because when fibrin, when the plaque is formed, we don't want excessive plaque. We want to remove the required one, so that blood can flow easily through this blood vessel and it's not clotted. Okay, so there is a balance between forming a clot and dissolving the clot. So if there is something wrong along the pathway, so diseases will happen. So this is another diagrammatic view of what is happening in the secondary hemostatic plaque. This one at the C, secondary hemostasis, where we have extrinsic pathway, intrinsic pathway, and common pathway. So the extrinsic pathway is played a role by factor 7. And intrinsic pathway there are a lot of factors involved, starting from factor 12, and then coming to factor 9, factor 8, and then come to the common pathway, which involve factor 5, 10, and lastly, at the end, factor 1, which is fibrinogen. So the fibrinogen, we convert it into fibrin. So the fibrin will cross-link and stabilize the factor 13 and forming a stable blood clot. Right? So this is a latest cell-based hemostasis, replacing the O1. This is the O pathway, but now this is replacing the pathway, but the same endpoint is just like the previous one, which is we want to form a stable blood clot. So in this new cell-based hemostasis, it started with initiation, amplification, and propagation. But at the end, what you want is the stable blood clot. So this is the coagulation factor named from 1 to up to here. This is including the coagulation factor and anticoagulation. So what I want to emphasize in this diagram is the half-life of the plasma half-life of the coagulation factor. If you can see the factor 5, for example, is only 15 hours, and factor 7 here, only 5 hours. So this is not stable factor. That's why we need to process, especially the APTT test, within 4 hours as soon as possible. Because after 4 hours, these factors might degraded. So it gives false prolonged APTT due to the delayed transport to the lab. So they have different plasma half-life. So certain factors are very labile, namely factor 7 and factor 5. So majority of the coagulation factors are made in the liver. As you can see from here, I highlighted here, liver. So if you have problems with liver, if you have like CA of the liver cirrhosis, of course, this will affect the production of the coagulation factors and thus make your coagulation test prolonged. So you have to correlate the test result with the clinical presentation ataupun clinical disease of the patient. Okay. So for Coagulation test, we have screening test and further test. So the screening test, usually we do PT, prothrombin time, INR, which is derived from the PT, and APTT. So from this basic test, whether it's prolonged or not, we decide from it whether we want to do further tests such as thrombin time, bilirubin level, mixing study, coagulation factor assay, or factor inhibitor study. This all depends on the screening test first. But of course, before you do further test, you need to interpret very well the reading of the PT APTT, whether it's a real reading or a false prolonged reading. And you also need to correlate with the clinical. You cannot interpret result just based on the test because it involves many factors. Okay, let's look at the first screening test, which is the prothrombin time. What is PT? PT time, it measures clotting time after addition to plasma of calcium and thromboplastin. The thromboplastin is the reagent which mimicking is what happened in our body, our real body. It replacing the tissue factor and phospholipid. Okay. So it's part of the platelet substitute lah, menggantikan platelet. Sebab dalam platelet ni sebenarnya banyak phospholipid. So phospholipid ni menggantikan platelet. So this PT time, prothrombin time, reflects the activity of the extrinsic pathway, which involve factor 7 just now. And also common pathway, starting from factor 10, factor 5, factor 2, and factor 1. Okay? So either this factor deficient or there is inhibitor towards it, the PT will prolong. Okay? The thromboplastin, we use different sources to prepare the reagent. Example, it can made from human placenta, from the rabbit brain, or recombinant preparation. So that's why when different lab use different thromboplastin sources from different factory, it can produce a different PT result on the same sample from different laboratories. Okay, it depends on what type of PT reagent you use in your lab. Because it can give different value because it's made from different sources. All right. So in attempt to standardize the PT value because of these different sources, we use INR instead of PT, right? Because we want to standardize the reading. But anyhow, you don't rely on NR itself. You need to combine everything. You need to look at the PT, INR, and APTT to interpret clinical situation. Like I say just now, this is the extrinsic pathway. This is reflected in the lab, right? So this is what we are measuring, the factor 7 pathway in the extrinsic pathway. So in the test tube, we add calcium because it's a part of the process. You see here, calcium here. So we need to add calcium manually. Thromboplastin and citrated plasma. This is patient plasma. So we want to measure the function of the factor level, factor 7, whether it's function properly or not. And if it's prolonged, it could be deficiency of the factor 7 or inhibitor towards factor 7. Okay, the INR just now we talk about, it has no unit. It's the ratio between the patient PT and also geometric mean of normal range. So by definition, is the PT ratio equivalent to using the WHO International Reference Preparation as the source of thromboplastin in the performance of PT. So how to develop INR? Normalize the PT by comparing with the mean normal PT, geometric mean of PT of the normal healthy population. And how this is get? How do we get this value? We take 20 control subject using specific lot of thromboplastin with a particular instrumentation, and the mean value change because we need a specific lot because the mean value changes with each new lot of reagent. Okay, so we have to use all the same. So the ratio is raised to power of designated ISI, and this reflect the function of the thromboplastin reagent. This one. So we get the thromboplastin from the WHO. Inilah international reference preparation. So normally INR is between 0.9 to 1.1. Okay. Each manufacturer has in-house standard or a specific lot on its own thromboplastin that has been carefully calibrated against one of the WHO standard. The ISR is calculated as a specific correction factor for a manufacturer's standard against the WHO reference preparation. And the ISI for a particular reagent is instrument dependent, whether the machine is optical based or mechanical based. And for commercial manufacturer of thromboplastin reagent are working to produce a ISI value close to 1.0 to minimize discrepancy between lab in reporting INR value. So INR is used to monitor long-term anticoagulant, and the definition of ISI does not include patients where the PT is prolonged due to systemic disease, such as severe liver disease. So IDR does not predict bleeding tendency in patients with liver failure or other systematic disease. Moving to the second screening test, which is the APDT. This is also done in vitro in a test tube. So it measures clotting time after addition to plasma of calcium and the APDT reagent. And this APDT reagent are phospholipid, which substitute the platelet, and surface activator. Example, kaolin. Okay. So the clotting time, the APDT time, tests the integrity of the intrinsic and common pathway. The intrinsic, just now we've seen many factors, right? Factor 12, factor 9, factor 11, factor 8, and also common pathway, same as like PT just now. Measure the common pathway, factor 10, factor 5, 2, and factor 1. So it measures this part, intrinsic pathway and the common pathway. So it measures the integrity of this factor along this pathway. So if it's prolonged, it could be deficiency of the factor or inhibitor towards the factor. Okay, so in the test tube, we add, as usual, we add calcium, we add the patient plasma, we add the phospholipid, replacing the platelet, and also activator kaolin. So you want to know whether we want to measure the time taken for complete fibrin clot formation. Okay, it's prolonged, meaning there is something problem with the factors inside this pathway. Okay. So, right. This is the clinical scenario which can give different value of the coagulation profile. So, if you do a series of panel which includes TT, fibrinogen, FDP, bleeding time, and platelet count, you need to combine everything to come to this diagnosis. You cannot rely on this just PT APDT. Okay. So of course, for full blood platelet count, you can get it from the full blood count, right? And bleeding time, usually not done as a routine, but you can done if patient having bleeding tendency, right? So for example, let's take one example, like a factor deficiency in the extrinsic pathway, like this one, 8, 9, 11, and 12. So what we see, the APDT is prolonged, increased, right? So we can tell here that there is something problem with the factor in the intrinsic pathway, right? PT is normal because it's not affecting factor 7, right? And platelet is normal, bleeding time is normal, and thrombin time also normal because it doesn't affect the common pathway. Fibrinogen also normal, level 1. Fibrinogen is another name for it, is factor 1, right? So ADP is also normal. So this is an example that can be seen in hemophilia A or hemophilia B. Or patient on anticoagulant heparin. Because heparin is the inhibitor towards factor inside the intrinsic. So this test has limitations. Coagulation screening tests can be meaningfully interpreted only with knowledge of their limitation and the relevant clinical situation. And it can be divided into general or specific limitation. Okay. For general limitations, it's the in vitro assay, the clot formation in a test tube and require the addition of exogenous reagents. Just now we add what? Calcium, we add the thromboplastin, right? So the interpretation requires caution because it do not accurately reflect in vivo hemostatic response, because it's only a test tube test. That is first. Second limitation, we need to know about normal biological variations. Normal range is usually derived from disease-free subject and defined as result falling within 2 standard deviation above and below mean of normal population. And bear in mind, about 2.5% of healthy subjects have prolonged clotting time. So normal variation meaning that like this is the bell shape. So we take it this is as the normal population, right? And it depends on different population have different normal biological variation. For example, in neonates, they have different normal variation. In adult also has different, and also in elderly also, they might have different range. Third, insensitive to some clinically important bleeding disorder, especially in mild hemophilia A or mild von Willebrand, because it can cause false reassurance. It can cause normal APTT value in mild cases. As we say just now, the value depends on the reagent used. So sometimes the reagent used are not so sensitive towards mild deficiency of factor 8 or factor von Willebrand. Okay, so that's why we can miss. In certain case, we can miss patient who has mild hemophilia or mild von Willebrand. Because of what? Because you see there is a normal APTT value. Okay, so that's the limitation lah. Some reagent are insensitive. It's not so sensitive. So that's why bleeding score and history is very, very important compared to test. You need to assess the bleeding history accurately. Number 4, artifact due to sample collection or pathological condition. Okay, this is more towards pre-analytical factors like prolonged tourniquet, difficult or traumatic phlebotomy, inadequate sample volume, heparin contamination, or high hematocrit, which you can see in smokers, right? Or patients who have heart or lung diseases. So these factors can affect the value of the coagulation result and give false diagnosis. Okay. That is general. For specific limitations, we can divide it into different category. First category is technical variability. Like for APTT, the technical part that play a role is maybe you use different APTT reagent and also different endpoint detection. Okay. Significant differences in the sensitivity coagulation factors, deficiency or inhibitor, ideally can detect around when the factor is 45 or 50% below than the normal range. But some reagent or instrument only cause prolonged APTT when the factor it is less than 30%. See the variation. Some detect prolonged when it's less than 50% or 45%, but some below 30% baru the APTT nak prolong. That's the technical limitation lah, depending on the reagent. Okay. For PT, differences in the composition of the PT reagent can result in variable sensitivity and only prolong once factor level drop to less than 50%. Okay. This is for the PT. And second category limitation is about patient's disease or physiological. For example, in certain physiological situation like in pregnancy or patient having stress or trauma, factor 8 rise markedly. Okay, it will rise. Okay, when it rise, you might miss the disease, the pathological disease. It can shorten the APTT. It doesn't prolong the APTT when it rise. So you need to correlate with when is your timing when taking the blood. Is it patient under stress? Is it trauma? So it might not give a good result. You need to repeat the test. Okay, detection disorder that are not associated with bleeding tendency. Okay, two common causes of prolonged APTT such as factor 12 deficiency and lupus anticoagulant. They are not associated with bleeding. Okay. And for prolonged PT is associated manifestation of LA, lupus anticoagulant. It can sometimes can cause prolonged PT, but mainly for LA and factor 12 deficiency, they can cause prolonged APTT without bleeding. Like I said just now, we talk about the issues that affect the result, and most of the causes happen at the pre-analytical area, about 46 to 58%. This is found in this journal, in this paper. And examples of the pre-analytical errors are incorrect analysis order, test is not marked correctly, incorrect test result, test request loss, patient identification error, patient preparation error, mislabeling, sample collection error, incorrect handling of sample, and transport error. And then analyticals is not that much because it's in a controlled environment. So if it happens, it contributed by sample loss, sample mixed up, equipment failure, or analytical error. And post-analytical examples are test result loss, TAT time prolonged, transcription error, or incorrect interpretation. But the most important one is we want to target the pre-analytical error because this is the most common cause that give the false result of the coagulation test. In the test, we also involve in quality program, which involve internal and also external quality control. So the main point of having internal or daily quality control is because we want to detect day-to-day variation or within the day variation of the result. We want to ensure that the result is accurate and precise. So in external quality control, we involve hiring we are paying a certain amount of fees to involve the external agencies, which they assess our result and comparing with other lab which use the same method as our. Okay, this is the most important topic, pre-analytical variables. What are the things that we need to look for to get an accurate result? First is positive patient and sample identification. This is very crucial. Okay, patient misidentification errors potentially associated with worse clinical outcome due to misdiagnosis and inappropriate therapy. If you dah tukar tube dengan patient, tiba-tiba you label patient yang normal ni sebagai prolong. Okay, jadi akan misdiagnosis and akan bagi inappropriate treatment towards the patient. So you have to identify correct patient. So main causes that this might happen because same name, they are neighboring bedside, switching bed, wrong labeling, mixed sample, or in a busy ward or clinic. So you might mislabeling or change the sample. So you need to have a proper patient identification, ask their name, okay? Always double check patient name with the RN and IC number and use two patient unique identifiers, whether RN or IC, name with or name with the RM, okay? And follow the procedure and SOP, and you need to do this procedure in a calm and focus. Don't multitask when you take the blood. Second is sample collection. All tests have specific collection requirement, and most coagulant tests you have anticoagulant citrated base, about 3 to 2% sodium citrate inside the bottle. So when you are collecting the blood, you should collect according to the order of draw. If you want to take many blood samples, you must follow it with blood culture first, and then followed with the coagulation test. And then when you withdraw the blood, then the blood can be transferred into this tube lah, serum tube with or without clot inhibitor, heparin tube, ADPA tube, and lastly, glycolytic inhibitor tube for random blood sugar, right? So you must remember this very well. You cannot mix up the order because it will affect the test result. Venipuncture phlebotomy, common problems. This is, commonly happen in our IPPT ward or clinic. The doctor or nurses might draw blood from IV infusion or heparin contamination. So you will dilute the sample with normal saline, right? Or you can dilute the sample with heparin, which cause forced prolonged APTT. Second, applying tourniquet more than 1 minute. It may cause hemoconcentration. And also, when there's turbulence of blood, the blood can lyse too. Slow venipuncture. So if you do it too slowly, you will encourage clotting and activated sample, and use inappropriate narrow gauge needle, leading to the clotting and hemolysis of the sample. Because when there's narrow needle, there is an increase of turbulence of blood inside the needle. Okay, incorrect blood to anticoagulation. Usually we put 9 volumes of blood to 1 volume of anticoagulant, and you have to ensure that it fills at the marking area. Because if you put underfilling blood, it will increase the citrate level. Underfilling blood, the increased citrate in the tube will bind to the calcium, which can cause prolonged result. If you put the blood is overfilling, there will be inadequate anticoagulant to prevent clot. So the citrate cannot bind with excessive plasma that you put. So the APTT will be shortened. You see, this can have forced prolonged and forced shortened result. So that's why you need to put according to the label, according to the line in the tube. Okay. So when you put there is underfilling, no, if the hematocrit more than 55%, like for example in diseases like patient is a smoker, patient has lung disease or heart disease that can cause high hematocrit, you have to be careful because it will cause prolonged APTT. It considered underfilling, same as underfilling. It cause post prolonged APTT. So in what you need to do in this situation when you have high hematocrit patient more than 55%, you need to call the lab. You need to inform that this patient from the full blood count, I found out that the hematocrit is high due to the underlying illness. So the lab role is to withdraw some of the citrated inside here, and then give you back with a tube with less citrated sample. So we have a formula for that. This is not your role. This is a lab role. We will calculate based on the formula, using this formula, how much volume need to be, how much volume of the citrated need to be taken out from this tube. And we have to bear in mind also, blood should never be transferred from one collection tube to another, even for 2 sodium citrate tubes, because it can cause doubling up of the anticoagulant citrate levels, right? And you should mix thoroughly 3 to 6 and over tube inversion for adequate mixing to prevent blood clot. You have to make sure the blood and the anticoagulant mix together very well. That's why you have to invert it up to 6 or 8. So the way of inverting it is like this. This is considered one inversion, right? So you need to do it 3 to 6 or 8 inversion. Okay, there is a guideline for how much inversion you need to do, but in general, to be safe, minimum at least 8 lah, right? 8 for all the tests you need to invert. The main aim is to just one, to mix it properly so that it mix well with the anticoagulant. Because we don't want blood to be clotted. Okay, sample transport. You need to transport at room temperature. What definition of room temperature is between 15 to 20 degree in a short time as possible. The test should be accomplished within 4 hours of collection. As I said just now, delays may affect the level factors such as factor 5 and factor 8 just now because they have a lower half-life. When they are destroyed because you run it more than 4 hours, it can give prolonged clotting time and thus affect your management. Sample processing and storage. The test performed on plasma derived from one centrifuge sample at room temperature. For LA, lupus and leukocytosis, you need to double spin. And if you cannot run the test immediately, you need to store the plasma by put it in the freezer lah. It can last about 2 weeks if under -20 and about few months under -70. Okay. Okay, this is the sample collection that the lab can receive. First is maybe lipemic sample. Patient who has familial hypercholesterolemia. Sometimes we cannot avoid it. The patient is lipemic like this picture. So what are the effect of the lipemic sample? It can elevate the factor 7 and effect on platelet function because it disrupt it covers the platelet membrane, so the platelet cannot bind together. And second, the lipemic sample can interference with the optical base clot detection in the machine if the machine use the optical base method. But if your lab doesn't use this optical base method, then it's not a problem. Okay. So how to avoid this? You need to fast the patient. And secondly, using mechanical or electromechanical base method machine lah. But nowadays, I think we don't have problem because in the newer machine, although for optical base method, they also have different multiple wavelength to overcome the lipemic sample problem. That's a new machine lah. This I'm talking about old machine, which my hospital might still be using it. Okay, second problem is a hemolyzed sample. What it affects is it increases the fibrinogen, the level factor 1, and also increase the dimer. And it also increase the spectrometric absorbance of plasma sample with high background absorbance readings. So what you need to do in the lab, if grossly hemolyzed, we should reject because it will affect the result. And also some machine, we have a mechanical point detection system, the latest detection. They can minimize the interference by the hemolyzed sample by giving quite accurate reading. But this is mainly for mild hemolyzed lah. But if a grossly hemolyzed, you should reject it. You cannot run it. It's unethical. For patient-specific factors, you need to interpret cautiously lah, depend on the age and also physiological condition. For example, at birth, vitamin K dependent coagulation methods are reduced because the liver is still immature and they don't have enough vitamin K to be produced. That's why sometimes baby, newborn, we need to inject vitamin K because their liver cannot produce vitamin K. So if patient born at home, maybe they don't bring to the hospital early, there'll be risk of bleeding in a newborn. So that's why you need to have delivery at the hospital because we want to give vitamin K. Physiological variations, pregnancy will increase factor 8, bombazine, and fibrinogen. This can cause shortened APTT. So when you interpret it, you need to be cautious. This is the summary that I talked just now. The pre-analytical factors, blood collection. You have to prevent. You have to do it quickly because you don't want blood to be stasis too long. Don't put tourniquet too long. And you just use 21 gauge needle or butterfly in a difficult patient. Okay. Do not use heparin contaminated venous line. Ensure correct filling of the tube, right? Inversion 5 to 6 times. And if the hematocrit more than 55%, you need to ask the lab to adjust the volume of the citrated inside the tube. Okay. Handling must ideally within 1 hour at room temperature. So for APTT, must not more than 4 hours. But for PT, it's still acceptable because factor 7 doesn't affect it that much. Storage and preparation, avoid prolonged storage at 4 degrees. So you need to analyze within 4 hours. And if need to be frozen, you need to put in the -20 or -70 degree. Okay. And prior to analyze, after removing from the fridge, you need to thaw at 37 degree lah. And mix gently to resuscitate any cryoprecipitate. Okay, right. Okay, this is just the same what I talked just now lah. Overview or purpose of hemostasis testing. Okay, why you send all this blood? Okay. First, we want to assess the screening. We want to screen or to assess the risk of hemorrhage prior to an invasive procedure. Okay, but structured bleeding history is much more powerful than lab test to predict bleeding risk. So you don't rely on the test. If you want to assess the bleeding assessment, you need to do bleeding score. Patient who did not show bleeding tendency during prior hematopoietic stress, like dental procedure, trauma, or childbirth, are unlikely to have significant congenital bleeding disorder. Okay. In the history, you need to ask whether they have during their dental procedure before, do they bleed easily, ataupun waktu melahirkan anak, adakah banyak kehilangan darah melebihi, daripada normal people. Kalau trauma terjatuh sikit, adakah mudah lebam. Benda-benda macam tu ada dalam bleeding history score lah, you kena tanya. Kalau tak ada, meaning unlikely lah mereka ada congenital bleeding. Maksudnya dia orang bukan ada penyakit keturunan penyakit darah. So according to the BH guideline on the assessment of bleeding risk prior to surgery or invasive procedure, the they do a study from 9 observational, which 3 of them is prospective study, and what they conclude is clotting time is a poor predictors of bleeding. Okay. What kalau tengok ni pun tak orang faham kan. So just nak bagi conclusion yang kata bleeding rates for patient with and without abnormal coagulation test was similar. So nak katakan kalau APT tu normal atau APT abnormal pun dia tak predict pun patient tu will have like bleeding likely or not during the operation. Okay. So the summary of key recommendations. Indiscriminate coagulation screening prior to surgery or other invasive procedure to predict post-operative bleeding is in unselected patient is not recommended. A bleeding history, including the detailed family history, previous excessive post-traumatic or post-surgical bleeding, and the use of anti-thrombotic drug should be taken in all patients pre-operatively and prior to invasive procedure. So bleeding history is very important. Inilah poin-poin yang kena tanya lah. Family history, adakah penyakit keturunan thalassemia ke, penyakit keturunan hemofilia ke, mudah berdarah ke, ada penyakit platelet ke, right? Post-traumatic excessive bleeding dalam dental tadi saya katakan, adapun berkhatan ke, pembedahan sebelum-sebelum ni, melahirkan anak, semua you kena tanya dalam bleeding history. If the bleeding history is negative, no further coagulation testing is indicated ideally. Kalau tak ada history negatif tu, tak perlu buat. Sebab kalau dia buat pun nanti, it doesn't give any value. Right? If the bleeding history is positive or there is a clear clinical indication like liver disease, a comprehensive assessment then is needed lah, guided by clinical features. Okay, this is where the role of coagulation screening test is indicated lah. Second, monitoring the role of coagulation profile is to monitoring the effect of hemostasis system modifying drugs. If patient on warfarin or unfractured heparin, variable dose response and must be closely monitored to prevent under or overcoagulation. That's why you do FPTT or NR, right? Because we don't want to overcoagulate the patient or undercoagulated. Okay, usually we give this drug to prevent clotting, right? So kalau you bagi terlebih, patient akan berdarah, bleeding. Kalau you bagi kurang, clotting tu akan terlebih dan membuatkan blood vessel clotted, right? So you need to monitor by coagulation, coagulation test. Okay, unlike many other drugs, drug monitoring hemostasis is typically monitored by measuring the effect rather than the concentration of the drugs because two major reasons: complexity of the coagulation systems, large patient to patient variation in their effect at similar concentration. So patient ni different. Kalau you bagi same dose of the drug, they have different responses. So they look at the responses rather than the drug of the concentration of the drug. Measure the effect of drugs on coagulation system more rapid and more accessible than the concentration base. So that's why when patient on drug, we don't really see the dose of the drug, we see the result, the effect of the test. Third is the diagnostic workup to assess risk of recurrent thrombosis or bleeding in patient with unexpected thrombotic or hemorrhagic event. Okay, this is the most challenging. It involve multi-step process that start with screening test first, and then when it's abnormal, baru kita proceed dengan further test. For example, kalau ada prolonged FPTT, you might suspect patient having hemophilia A ke, inhibitor towards factor 8 ke, ataupun you have lupus anticoagulant. So you need to do further workout by measuring the factor 8 level, you do the LA workout. So that's what it meant lah, because it need further tests. So this is just to show you from Pusat Darah Negara for thrombophilia screening, the indication and for LA and also indication for heritable thrombophilia testing. So it's not indicated, it's a specialized test. So you need to read all this indication which is you can find and in the website. And they also rejecting criteria if you send this test during acute event. As you know, when during acute event, most of the coagulation factors are not accurate. For example, factor 8 will be high. So that's why we don't want to misinterpret the result. Okay. For example, let's see a bit about the indication for LA. So LA ni, you need to have a workout for it if you have more than 3 unexplained consecutive miscarriage before 10 weeks gestation. More than 1 morphological normal fetal death after 10 weeks gestation. More than 1 preterm birth before 34 weeks due to severe preeclampsia, eclampsia or placenta insufficiency. Young adult less than 50 years old with ischemic stroke. Unexplained arterial thrombosis in young adult less than 50 years old. Unprovoked DVT or pulmonary embolism under 50 years old, or history of thrombosis or pregnancy morbidity in patient with autoimmune disease. So, when you meet this criteria, barulah boleh hantar LA. Okay. Sama juga dengan indication for heritable thrombophilia lah, macam protein C, protein S, antithrombin, APC. This all inherited penyakit keturunan. So, when do you want to send it? First episode of VT, unprovoked or provoked by minor risk factor under 50 years old. Muda. Bila muda dia memang kita akan work out. When you are estrogen provoked VT under 50 years old, you ambil estrogen atau OCP ke apa, you ada thrombosis, you need to be investigated lah. VT at venous thrombosis at unusual site kat brain atau mesenteric arteries, patient developing warfarin induced skin necrosis. Bila you given warfarin, tiba-tiba skin you hitam. So maybe ada penyakit keturunan. or selected patients with strong family history of unprovoked thrombosis or past history of provoked thrombosis from pregnancy, OCP or travel. So as I say, we reject when during acute episode, patient on anticoagulant, you should delete 2 weeks after stop therapy because it will affect the result. No clinical history provided, rejected. Provoked DVT pun rejected because you dah tahu apa penyebab DVT or PE tu. So no need lah kan kalau provoke. Retinal vein occlusion associated with underlying risk factor, diabetes, hypertension or hypercholesterolemia. This is a rejection. Because saya dah tahu dah benda ni disebabkan penyakit ni. So tak perlulah you hantar untuk workup for LA ataupun heritable thrombosis. This is the report from the PDN. Usually like thrombophilia profile report, kita measure lah LA, protein C activity, fibrinogen concentration. Dari sini kita akan tengok lah tak ada negatif atau positif. And we give conclusion, impression by consultant lah. Contohnya ini LA was negative. Anticoagulation antibodies for IG was detectable at a concentration 43. Okay. And anti-beta 2 glycoprotein 1 for IG was detectable. So patient ni ada LA, ada anticoagulopin yang these two type of ni lah, apa tu, LA inhibitor lah. Bukan yang biasa punya. So come to the question back, coagulation screening test, is it a routine in practice or not? So depends kepada apa yang kita cakap tadi lah. Kalau from the history is very strong, so it's a must lah kan. Kalau the history from the patient is negative, usually it's not indicated. Sebab apa? Kalau prolong, you kena buat further workout. Tengok-tengok, rupanya it doesn't give a significant value because it's affected by maybe pre-analytical factors. Maybe there is a factor 12 deficiency which do not give any clinical bleeding history, right? So even they go for operation, they also do not have problem with it. So in conclusion, ideally a structured bleeding history is taken and coagulation testing is undertaken only if there is concern about a bleeding tendency arising from the history. And all PT APTT sent to hematology laboratory should have clinical history and specific indication why you want to send it. You don't send it just for fun ataupun for reassurance. Okay. Okay, that's all. Thank you.
Terima kasih Dr. Hafiz di atas sesi ceramah tadi. Ada sebarang soalan ke daripada peserta? Ada nak share apa-apa pengalaman berkaitan dengan pendarahan ataupun kes-kes di ward yang memerlukan lebih penjelasan? Okey, Dr. Hafiz, sekiranya kita ada pesakit ataupun kes-kes bleeding yang mempunyai positif bleeding history lah. So maksudnya dia dah ada history of bleeding sebelum datang ke hospital. Jadi perkara pertama yang perlu dilakukan adalah untuk menghantar screening test dulu ya, PT, APDT dan juga INR kan?
Yeah.
Sekiranya result tersebut tidak normal, adakah semua kes perlu untuk further test?
Well, kalau positive bleeding history from the bleeding score is significant, more than 5, then you send the screening test, and if you found it's out of normal range, we need to investigate by hook or by crook. Because we already have bleeding history significant. Based on the history first.
Okay.
Kalau there is no negative bleeding history, bleeding score also low, PT is normal, usually we don't proceed for any further test lah. We need just to monitor the reading lah in subsequent follow up.
Okey, baik. Jadi apakah test yang available dekat PPUSMB dan ada test yang kita perlu outsource?
Okay, Di PPUSMB, kita setakat ni kita hanya offer untuk PT, FATT dan thrombin time lah. Besides that, further test tu macam fibrinogen level dan also D-dimer. Kalau further test yang memerlukan factor level AC ataupun inhibitor such as LE ataupun thrombophilia workup, we will outsource to to the private lab ataupun HUSM lah.
Okey,
Tujuan
baik.
sebab apa kita tak ada, sebab kita tak ada demand for it. So we don't buy the reagent lah because it's not cost effective. So it's better outsource rather than buying the reagent but we don't use it. So the main point is for ni lah cost effectiveness. Yeah.
Okey. Baik. Jadi kesimpulannya sekiranya kita menghadapi masalah ataupun kita merawat pesakit yang mempunyai bleeding problem. Jadi firstnya kena ambil detail history lah berkaitan dengan bleeding history dan kemudian kita proceed dengan screening test. Sekiranya screening test tu tidak normal, jadi bolehlah berhubung dengan makmal hematologi berkaitan dengan further test. Sebab seperti yang Dr. Hafiz sampaikan, cara-cara untuk mengambil darah untuk coagulation test ni dia special sikit kan. Dia tak boleh guna tourniquet yang terlalu ketat dan needle pun mestilah yang besar yang large bore untuk tidak mengaktifkan coagulation factor tersebut. Okey, ada sebarang persoalan lain lagi daripada peserta? Okey, sekiranya tidak ada sebarang soalan, so kita boleh tamatkan sesi kita untuk kali ini. Terima kasih banyak-banyak kepada Dr. Hafizuddin kerana sudi untuk berkongsi pengalaman dan juga pengetahuan dengan kita semua. So, terima kasih semua partisipan yang hadir. Mohon untuk isi kehadiran seperti dalam borang yang diletakkan di dalam chat box. Okey, terima kasih semua. Assalamualaikum.
Assalamualaikum. Malam.